I'm really quite honored to be invited to talk at YACS. First thing I should say about the Sherpa Project is the principal investigator for this study is Dr. Heimer. So he's my boss. He's the one who really kind of masterminded this whole study. Basically, I'm going to talk to you a little bit about some of the findings we've had with the Sherpa Project. Why Sherpa? Sherpa stands for Suburban Health Education Research and Prevention Alliance. For a lot of you who have done studies, you spend inordinate amounts of time trying to come up with just the right acronym. And what we really were trying to do with this one, it has nothing to do with Nepal. Nepal? Is it Nepal? Thanks. But we were looking to try to come up with some kind of title for this study that would not be highlighting active injection drug users as part of it, as a way of showing respect and trying to maintain the confidentiality of our participants. So today in the talk, I'm going to talk first of all about why we did this study, as Robert mentioned, go into detail about the methods, and then I'm going to spend a fair amount of time describing the sample. One of the reasons why I am going to spend so much time describing the sample is, to our knowledge, this is the largest study of non-urban active injection drug users. That is to say, not in treatment. There are several studies out there about suburban drug users and injectors, but they're usually already within the treatment setting. This is the first one that they're active and not in treatment when they are enrolled. And then I'll go into the primary analyses and conclusions. So the rationale, why did we want to do the Sherpa Project? It has been, I also again have to kind of give my hats off to Dr. Heimer. It took him a few tries to get this through and funded by NIDA ultimately, but there were indications up to 2 decades ago that, first of all, we had an aging cohort of urban, economically disadvantaged, primarily minority injection drug users, primarily heroin users within urban areas. There were already kind of hints from such databases as the drug treatment admissions, drug-related mortality, that's your medical examiner data, national surveys, and then data from ER, response, the emergency ambulance services and the ER admissions, that there was drug use, injection drug use, opioid use, was occurring more and more frequently out there beyond those non-urban areas. So, and as I say at the end, given all these hints, Dr. Heimer started quite a while back on trying to get a study really to take a closer look at who are these people, what are their risks, what do we need to do for them, do we need to do differently for them than what we've already done a lot in terms of HIV prevention and HCV prevention in urban areas, the interventions that have been developed for those, primarily for those areas. So the specific aims of this study are four. First, to assemble and follow a cohort of active injectors in Southwestern Connecticut. We are limiting ourselves, and we'll get to a map later on, to the counties of Fairfield and New Haven. We're going to collect quantitative data on sociodemographic information, and we will collect this quantitative data longitudinally. And then we're going to test the hypotheses about influences of the environmental context on HIV knowledge, injection practices, that's both risk and hygienic practices, and your knowledge and also seroprevalence of HIV, HBV, and HCV. HIV, everybody I think probably would know. HCV is hepatitis C, and HBV is hepatitis B. If I use some terminology that you don't know, please let me know immediately and I'll address it. And then the fourth aim is to determine the behavioral patterns that are durable and identify the factors that modulate the risk of infection of HIV and the other viruses over time. I will not be going into that fourth aim. We are still in the process of cleaning and analyzing the longitudinal data. So I will only be reporting on the baseline data today. So as far as the research methods, we've kind of I've already hinted at it. This is a multiple methods longitudinal design. We administer a quantitative interview every 6 months, starting at baseline. The quantitative interview is both face-to-face and ACASI. ACASI is a computer-assisted self-interview where we sit the participant down with a laptop and they fill it in themselves rather than doing it face-to-face with somebody. We draw a blood sample at baseline and then every year annually, and do our own testing for HIV, Hep B, and Hep C in our labs. We had a subsample of 43 participants that we recruited over the entire enrollment period, where we really wanted to look in a qualitative manner, and hence the multiple methods approach, to try to get at the more gray areas of how one's injection drug use affected employment, social interactions with friends and family, education, different income, different kinds of factors, involvement with substance abuse treatment, involvement with the criminal justice system. So we had this subsample of 43 where we did these in-depth interviews. The way they worked is we had 2 sessions per person. And those 2 sessions occurred within no more than 2 weeks apart. And both sessions were about 2 hours. So we had a total of 4 hours. It's a lot of qualitative data there for the qualitative researchers out there. We stratified, as I said, we enrolled over the entire enrollment period. We enrolled into the sub-study, but we also stratified by sex, age, and county of residence. Recall we have Fairfield and New Haven County. So this may be a little bit out of order, but here it is. These are the 2 counties, Fairfield and New Haven, and we excluded 6 cities: Danbury, Stamford, Norwalk, Bridgeport, New Haven, and Waterbury were excluded from our study. We considered those to be large cities. Those were urban areas. So we were only recruiting from suburban towns of Fairfield and New Haven County. So those 6 were excluded. The recruitment strategy was respondent-driven sampling. How many people are aware of this method? Do I need to go into it? It's about half. All right, so I'll give you a real short description. Respondent-driven sampling is a snowball sampling strategy that relies upon dual remunerations kind of system, where you recruit somebody called the seed, and you provide them with a certain number of coupons. In our case, we provided them with up to 4 coupons, and instructed them to go out and recruit people that they thought would fulfill the inclusion criteria to be successfully enrolled into our study. If that person that they gave the coupon to contacted us and then was successfully enrolled, we would then provide an incentive back to the person, the recruiter, that seed, would get $10 for every successful recruitment. And that's basically what respondent-driven sampling is about. How it's touted, the good parts to respondent-driven sampling are twofold. First of all, it's a very good way of going into a community that you may not know and recruiting a lot of people in a relatively short time, rather than by going the original traditional outreach method. In a study that we did in Maine several years ago, we were able, in one summer, we were able to recruit well over 200 people into a study that we were not familiar with the people or the community. We were able to get in via the respondent-driven sampling. We were able to recruit and enroll in a very efficient way. The other good thing to respondent-driven sampling is if it's done, if it works the way it's supposed to work, there are calculations that you apply to the data that are able to, you're able to calculate population estimates. So the bad news for us is we didn't achieve that. We did not have enough productive chains, because what happens is the first person recruits some people. Those people are then given coupons. They recruit more people, and you get these chains of people. We never got to that a sufficient level. I think 56% of our chains, of our seeds, were non-productive. And so we were not able to calculate population estimates. This has to be considered a convenience sample only. So inclusion criteria were you have to be at least 18. You have to have resided in one of the towns, excluding those 6 cities in Southwestern Connecticut and the two counties. The way we established this was you needed to bring a photo ID, and you needed to bring a piece of mail with your name and the address from one of those towns. And that's how we established residence in one of the suburban towns. You had to have reported that you injected at least once in the last 50 days. We tried to confirm this by either observation of injection stigmata. Sometimes that was not, you were not able to do that, in which cases we would have, our field staff would have a more protracted conversation with the person about their last injection experience to try in the process and what they went through to try to get at, do they really seem like they're an injector, or are they just kind of mouthing, yeah, I injected. The recruitment period, as noted, is from November 2008 until January 2012. And, you know, we followed everybody longitudinally for as long as the study went on. So it was a little bit different. Not everybody was recruited at the same time, so not everybody had as many follow-up interviews. So the types of data collected, first of all, sociodemographics, the usual suspects, age, sex, you know, race, ethnicity, educational level, income. We broke down into both legal sources of income as well as extra legal and perhaps gifts from other people in the last 30 days. Benefits, for the most part, the benefits were really, what we really were interested in was your health benefits and living situation. For the health history, we started out by saying, in general, how compared to other people of your age, how would you rate your health? And basically, it was on a 5-point Likert from poor to excellent. Then we asked about self-reported HIV, Hep B, and Hep C status. The way we constructed that was, we said, have you ever been tested? If so, did you receive the way we said it was like something, did a medical healthcare provider tell you that you were infected? So that's the self-reported, you know, of positive status for either Hep B, Hep C, or HIV. And then we had self-report of overdose experiences and also witness. Clinical measures that we included in our rather extensive quantitative interview included the addiction severity, which is very commonly used in drug treatment centers to monitor on several different domains, including legal problems, psychological problems, medical problems, problems with drinking, problems with drugs, problems with family. We use the Audit C, which is a screen for problematic drinking. Brief pain inventory is another measure that is routinely used in pain clinics. We chose to, and we have used it in many of our studies, on the assumption, and what we hear oftentimes, that a lot of people become addicted because of a trauma, a physical trauma, where they were prescribed opioids as pain management, and then it went on to become a more serious addiction problem. So we monitor pain in terms of the severity of the pain and how much does it interfere with your daily functioning. And then we had 2 screens, they're brief screens, for depression and anxiety. Finally, we had a 12-item social support scale to try to get a measure, a quantitative measure. Of course, we went into it a little bit, in more detail in the qualitative studies, but we got from all participants, we got at least this brief kind of estimate of rating your social support. Serologic data, this is us doing our own testing. We tested for HIV and Hep C. They're all by ELISA. Hep C and HIV, it's positive, negative. For Hep B, we did core and surface antibody as well as surface antigen. So there were 3 tests for Hep B. Other kinds of self-reported data included the injection risk and hygiene behaviors, access to syringes, to clean syringes, or to syringes in general. Knowledge of hepatitis, HIV, and overdose. We've used this on several of our previous studies. It's an adaptation from an HIV knowledge survey that was done, I think, in the 80s. But at any rate, we've been using it routinely. History of substance abuse treatment, and history of involvement with the criminal justice system. We also collected geospatial data. The most important, 3 most important variables for us to consider here is, what is your current residence, and then where did you purchase drugs most often in the last 6 months, and where did you inject most often in the last 6 months. And we really took this down to the town level. We do have it below that, but for purposes of this presentation, it's really only by town. And then, as I was saying, there's the qualitative in-depth interviews where we assessed for 12 domains, and we're still in the process of analyzing that data as well. So I'm going to drive this home a couple times for you. I want you to make sure that you understand everybody, all 462 people, reside in the suburbs. And the 2 groups that we compare are those people who inject most often in urban areas versus those people who inject most often in the last 6 months in suburban areas. So I'm going to talk about, I probably will talk about urban and suburban groups, but you have to understand everybody's from the suburbs. This is just how we've divided our suburbans further. All right, and I will repeat this again. So going on to the results, as I said, since this is really the first study, large study of suburban injectors, I really think that it's worth our while to spend a little time saying, what do these guys look like? So I think I skipped. All right, so the first thing is age. And this is kind of going on what I know from previous studies that we've done in urban areas. Mean age, mean and median, they're about mid-30s. It's a little bit younger than what I expect. In the urban studies that we've done in the past, they're probably early 40s. So they're a bit younger. I think that it's also of interest and of note that they have been injecting for a mean of 11 years. So these guys were starting in their early to mid-20s on injection drug use. Most likely they were using opioids for at least 2 to 4 years before they started injecting, I would say. The breakdown on gender is not unsurprising. Generally, I expect to see anywhere from 2/3 to 3/4 are male. So this is a little bit more female representation, but not really enough for me to make a big thing of it. I think it's also not surprising. This is predominantly a white population. This is Connecticut. This is Southwestern Connecticut. This is the suburbs. I think most of our minority in the state of Connecticut are in the larger cities. This is legal marital status. They've never been married. This says nothing about, and you shouldn't conflate legal marital status with living situation. They may be living with somebody, but the majority have never been married. No, yes, we did, but I didn't look at that. I didn't look at that. I haven't looked at anything. I'm not even sure if we did. I think we did, but I'm not sure. This is a study of injection drug use. We have kept, consciously, we have kept all sexual risk associated with HIV to a minimum. This is a long quantitative survey, as it was, and we really wanted to focus on injection risk. So I'm not sure. I'd be glad to get back to you. Yeah. Education, most of them had at least a high school education. I think this is a little bit higher than what I would expect to generally see. So there seem to be, I don't want to say well educated, but they do seem to have at least high school educations, and yet when you look at their income, they're really quite low. And then to make the scene even more, I don't know, sad, only about 30% are currently employed. Of those people that are currently employed, only about half of them are employed full-time. And then by the time you get down to, do they receive employee benefits, virtually nobody receives employee benefits. I mean, so I think that the economic disadvantage is still pretty evident when you look at these descriptive statistics. Somehow it's not going. Okay, I'm not able to move it. Hit escape. Yeah, it's not. Okay, well, I'll talk while Pete fixes. Since we're still just describing, this is pretty cool. I would say generally 2/3 of the people live with family or friends. Only about 20%, 29% of them rent or own their own residence, and very few of them have served, about 7% have served in military service. As far as criminal justice system, this is one that I actually really would like to show the slide for. The really astounding thing was that almost 90%, 89.8%, reported that they had ever been arrested. So these guys have a lot of involvement with the criminal justice system. So now I'm going to cascade until Pete can get us set up. So 89%, 90% really, are ever arrested. When asked of those people, how many of you were jailed? Thank you very much. Thanks. So, of those people, 80% were jailed. Now that figure there is holding cell, jailed for longer than that, or an overnight lockup. But 80% of them were ever jailed. 68% of them were convicted, but if you were convicted, chances were really very likely that if you got to the level of conviction, you were going to get sentenced. Now, the number of times that they were arrested was 9. I thought what was interesting there, average number of times that they were arrested was 9. About 1/3 of those were on drug violations. So they're getting in trouble. I can't say that those others were not drug related, but at least 1/3 of them were drug violations. For the number of incarcerations, the last figure that I give there, that is excluding holding cell and lockup. So those are true incarcerations where they're spending some time in jail. Got about an average of almost 4 times per, that they get locked up. So their involvement is pretty high. Health status, I like this. I always say that the world is broken up into a third, a third, a third. And basically in this case, it is a third, a third, a third. It's only about a third that say, yeah, I really feel like I just have awful health. Most of them are saying, yeah, I'm pretty good or excellent. What was very surprising was how well insured they were. Now, remember back to our employment stats. Most of these people are on Medicaid, Medicare, disability. They're on something. Most of them are getting their health insurance through some kind of government subsidized. Very few of them are getting private insurance. 8.7% said that they had private insurance. But they are relatively well insured from a perspective of health insurance. So for our seroprevalence, these were our tests. About 1%, almost 2, a little less than 2%, were HIV positive. Most of them were aware. That was the self-report part. The left-hand side is our lab data. Those are our self-report. When we talk about Hep C positive, about 40%, 41% of them were Hep C positive. I guess this is good news, bad news. It's pretty high, but compared to compared to a Hep vaccine study that we did where we screened for hepatitis 10 years ago, Hartford and Bridgeport, their seroprevalence was around 80%. And in injection drug users, it does tend to be higher. So it's high, but it's not as high as it could be. I think that's the take-home message from that. For Hep B positive, I kind of want to explain a little bit. The Hep B positive, what that really is saying is, because I don't know if you know, but most people will clear Hep B. So you get infected and 95% will clear it. They'll be done. My Hep B positive 24.4% there includes people, that were previously infected or are no longer infected. It includes carriers who are, currently acute or carriers currently infected. And then this murky no man's land where they test positive for core antibody only and we don't really quite know. We assume that they were infected, but they're not showing the normal serological evidence that they were infected. We assume that they've been infected. The 4.5, acute or chronic is about right. Of concern, now remember this is a young group of people. So, okay, I'm going to give you a little of my history here. So mandating for Hep B vaccination, I don't think started until the 90s. But my kids in the early 80s were getting vaccinated for Hep B. It was already, I think, fairly routine in most places to have your kid vaccinated for Hep B. The fact that 44.4%, and you also have to think, this is not an immigrant population for the most part. Most of these people are not coming from other countries. These are Americans. And for 44% of them still to be at risk for infection is pretty impressive to me. As far as about 31% of them were already vaccinated. I didn't put that up there, but I can give you that. As far as substance abuse history, these guys have done it. About 8% of them have ever been in treatment. It's not that surprising. The nature of substance abuse disorder is relapse is part of the disease. So you go in, you go out, you go in, you go out. So the fact that only about half of them were in treatment said that they were in treatment in the last 6 months, is not surprising. As far as injection behaviors, about 90% of them said that heroin was their drug of choice. Almost 3/4, 70%, 2/3, whatever, bought their drugs in urban locations. However, almost 60% of them went home to their own residence to inject, in the past 30 days when we asked how, where you went. So they're buying in the cities, but many of them are coming home to inject. As far as syringe access, it made sense to us in retrospect. Very few of them, only 3.5% use syringe exchange. Now you have to think about, the two counties. The two syringe exchanges are Bridgeport and New Haven. That being said, it's a hell of a schlep for a lot of people to get to the SEP. So going to a local pharmacy, it's not surprising that 3/4 of them are getting their syringes from pharmacies rather than syringe exchanges. The sad part about that is, people who do go to syringe exchanges get much more than just syringes and supplies. They get information. They, people talk to them about harm reduction. They get referred to substance abuse treatment. These people are not getting that, I would think. All right, about 1/3 of them said that they have experienced overdose. The median number of times that they had personally experienced overdoses was 2. Almost 70% said that they had heard of Narcan. Narcan is, I don't know how many of you, particularly now that Hoffman, died, Narcan is what is used to reverse opioid overdoses. But this is pre-Hoffman, but I think there's much more in the media right now about Narcan as a result. But they were fairly aware about it. As far as injection risk behaviors, I want to kind of point out a few things. The number of injections for the last 30 days, mean number of injections is 70 times. I expect most kind of firmly ensconced injection drug users to be using daily 3 to 4 times. So I am not surprised. I kind of expect, if you ask them how many times in the last 30 days, I expect to see something in the 90 to 120 range. So these people are not injecting quite as much. Shots per syringe, I think that's fairly anticipated from our urban studies. That's about what I expect to see. Now, we asked about all sorts of injection risk behaviors. We pooled them. The bolded one, engaged in any of the following, is a pooled figure. And it is kind of concern that over half of them engaged in at least one of those risk behaviors at least once in the last 30 days. So the risk is not inconsequential. I think that a couple things for me to point out to you is, first of all, Steve Kester, an ethnographer in Colorado, has done a lot of work where he's gone out in the field and observed injections. And he has found that when people split drugs, either in dry or liquid form, certainly much more in liquid form, what generally tends to happen is somewhere along the line there is a breach in injection hygiene. So even though the people who are splitting the drugs really think that they're keeping everything safe and separate, in actuality, when you have that third observer, that ethnographer in the room with them, that isn't the case. So we added in those questions to really look and see at splitting. And splitting, in dry form is certainly over half of them are splitting in dry form. But, every 1 in 5 are splitting in liquid form, which I think is far more risky. The other things that are of concern to me are sharing of water, both the drug mixing water and the risk water. I think this is a very good opportunity for particularly Hep C infection. And then, of course, sharing syringes. That is there, too, as a concern. All right, so here I am ramming it down your throat one more time before I go into the primary analyses. Everybody is from the suburbs. What we're doing is splitting into those who inject most often in the last 6 months in urban areas versus those who inject most often in the last 6 months in suburban areas. All right, so our first hypothesis was that our suburban injectors, and so I've now started to use urban and suburban groups, okay? We're saying that they have perhaps a less stressful lifestyle. This is not what I wanted to show you. Oh, yes, it is. I'm sorry. Sorry. So in our bivariate analyses, the only thing that we really found out was that our suburban injectors tend to be more likely to have health insurance. They also tended to be older, and I guess as, you know, kind of co-varying with that is if they're older, they probably have been injecting for a longer period of time than your urbans. But really, essentially, for the by and large, these guys didn't differ too substantially from each other. Sex, race, religion, employment, income, you know, encounters with CJ system, number of partners, basically they're equivalent. Okay, so for hypothesis 2, basically what we're saying there is that your suburban injectors would have riskier behavior. Our reason for this, and I've already hinted at it, is they're not getting to those harm reduction programs that are probably more prevalent in urban locations. They're not going to get their syringes from these places. So they're just not going to know as much, and they're probably going to engage in riskier behaviors. What we found when we did that was actually the urban people that we thought were going to be safer injectors because they're exposed were actually the ones that were riskier. Thinking about it, however, we were thinking, these guys all live in the suburbs. The people who are injecting most often in urban areas may not have all the amenities that they may have at home. They may be hiding from friends and family that they inject. So they're choosing to inject in other places. They're injecting in, you know, galleries, shooting galleries, public places, parking lots, hallways. They may not have all those things, and so because of lack of, you know, appropriate kinds of equipment for injecting safely, they are engaging in riskier behavior. The other thing that we found was females tend to be at higher risk for engaging in injection-associated risk behaviors. I think that that has been shown in other studies as well, and we can talk a little bit more about that later on. Third hypothesis is that the suburbans would be less, the suburban injectors would be less knowledgeable, again, because they're not exposed. They're just going to be less knowledgeable. What we found there was, again, no difference in knowledge between whether you inject most frequently in urban areas or suburban areas. They were equivalent. However, being white, having at least a high school education, or more than 6 partners were associated with you having higher knowledge, and here it's a combined HIV, hepatitis, and overdose knowledge that we're assessing. So those 3 factors really were associated with better knowledge. I look at these and say that probably this is actually going back to an old study from Dr. Heimer where he was looking at diffusion of benefits. This was in the beginning of SIRA, on the hypothesis that that information, harm reduction information, would diffuse from syringe exchange programs to people who use syringe exchange programs to their friends who may not necessarily use exchange programs, but they're just talking and injecting together or hanging out together, and so they'll give information that they learn from from the syringe exchange. Here, I think having more partners, you probably are more likely to talk about. I would think that this could be one way to account. You're just talking, and so you're learning. You're gaining from your colleagues, gaining knowledge about HIV, hepatitis, and overdose. The downside to this, okay, two downsides. First of all, true-false kinds of questions, and this is a true-false question, tend to overestimate knowledge. I don't want to go into it, just accept what I'm telling you. It's an overestimate of knowledge. The average overall knowledge score was 59%. So I'm saying these guys are probably not much better than chance at answering these questions. Their knowledge, they may be more knowledgeable, but they're not all that knowledgeable even in the best of situations. There were some people that got 90%, but I just wanted to put this kind of in context for you. All right, last hypothesis. We hypothesized that the Suburbans would have lower seroprevalence. So this makes no sense to us because what I've said is we expected the Suburbans to be riskier. We expected our Suburbans to be less knowledgeable, but now I'm saying we're expecting our Suburbans to have lower seroprevalence. How can that be? It's because this is a younger, we're less far along in the epidemic. This is a relatively new, this being injection drug use and heroin use, is relatively young in the suburbs, so that the bringing of disease will lag a little behind the wave of the problem of opioid use and injection drug use. So that's why we said that we thought that they were going to have lower seroprevalence. I hope that makes sense to everyone. What we found, actually, okay, let me go back here. We found no difference for HBV or HCV. We couldn't test for HIV. You remember we only had 7, no way to compare. So, but we found that there was no difference in seroprevalence between the two groups. We went to co-infection since we really could not do anything, and we looked at co-infection. So what I'm going to report here is actually not quite what we hypothesized, but this is what we found. We found that, again, having at least a high school education was protective of being co-infected. Co-infection here defined is having 2 of any of the 3. Okay. The other thing was the longer you had been injecting, the more likely you were to be co-infected. I think this is something that makes a lot of sense to most of us. It was not surprising. Okay, so conclusions. First of all, we can characterize the sample as basically being white, young, single, and most of them having completed at least a high school education. Whether you want to call that well-educated or not is up to you. Of concern to us, however, is the low income, the high unemployment, the frequent interactions with the CJ system, and the injection risk behaviors. I want to talk a little bit more. From our qualitative data, it is a huge problem and a big concern to our participants. Lack of money, trying to find a job, can't find a job. The whole financial disadvantage of these people is right there in our faces practically on a daily basis in our interviews, in our in-depth interviews. The frequent interaction with the CJ system, the bad news, I guess, is that you don't see, living in the suburbs doesn't seem to protect you very much from involvement with the CJ system. It's a double-edged sword in that, again, mostly from the qualitative data, a lot of times this enables you to get into treatment, either for 2 reasons. Either you're seeking to mitigate your charges or sentencing, so you go because of your CJ problems, or you go, to drug court and you're sentenced to do treatment. So criminal justice can also be seen in some way as a harm reduction effort in that they do get a lot of people into treatment. Again, for the injection-associated risk, we really need to work on don't split drugs. If you are, let's talk about how you're doing it. There are ways to protect, make it safer. Don't share water and don't share syringes for the most part. As far as injection risk behaviors, as I said, we found, but I've also explained, we were surprised that we were seeing that it was the urbans who were more likely to engage in it, but I think that's because they don't have the amenities of home. We need to do things for females. I think that there are things that are inherent in the injection process. These are very consistent with other studies done over time in many regions, that the dynamics of the injection environment oftentimes puts the female at a disadvantage. I'm not prepared to tell you today how we can work with this. All I can tell you is this is something that's seeing consistency and needs to be addressed. Either we need to have to understand better what we can or cannot do, and then design interventions. As far as the knowledge, we saw that, people do talk to each other about knowledge, and that's good. Co-infection, it was not surprising to us that the longer you've been injecting, the more likely you are to be co-infected. This whole thing of level of education, perhaps the people who made it through high school were getting some kind of, in their health class, they were getting some of this knowledge that other people weren't getting, and so they were protecting themselves from co-infection. I don't know, but I do know that my take-home message from here is we really need to start thinking about innovative technologies and innovative venues for getting the word out. One of the innovative venues that I would suggest is pharmacies. That, we should be making better use of pharmacies for people who just may have missed out of it, earlier in life. And in conclusion, the limitations. First of all, this is not a probability. I told you this is a convenience sample, so we have limited generalizability. The other thing, and I think you can say this about most, if not all, RDS studies, is that you are not getting those upper income people. Let us face it. If I am sitting there in Cos Cob or Greenwich, with my six-figure income and my wife and my 2.3 kids, there probably is no amount of money or any kind of incentive you can offer me to make me want to be part of your study. Okay, then self-reported data. We all know this one, that recall bias. We did what we could in terms of programming much of it to be an ACASI to try to get more valid estimates. The biggest limitation to our study is that we do not have an urban IDU group. And not to get too defensive, but when Dr. Heimer went to NIH with this application, there was in the research design a comparison group of urban injectors. The review committee, in its infinite wisdom, decided to fund this project, however, remove the urban comparison group. And this is truly, the fact that we're not seeing more differences. These guys are all basically suburban guys. So I'm sorry about that, but it is what it was. I'd like to also thank NIDA, first of all, for funding this. Dr. Heimer was the PI, especially all our participants and the research staff, particularly Community Health Service in Stratford was a methadone clinic that we used that was very helpful in terms of providing us. We got people as they were entering methadone, but they had been using within the previous 30 days, and they provided a place for us to go and interview down there, which was quite lovely. Wilson Palacios has also helped us with the qualitative data. Amisha, who has left, did all our blood work. She was beyond fantastic. And we have some great, Chris Hennigan, I don't know if Lisa's here. Lisa is here. They were fabulous out in the field. And that's it. Thank you.